Hey guys, this is Holly. How are you today? All right, so we're going to go over a clinical foam dressing application. And just in the beginning, I do want to let you guys know that we used a wound butt for sort of demonstration purposes only, of course. So as far as like the anatomical location of the wound, it may not be appropriate that we didn't bridge in this particular one, but it's just again to show how the application process takes place. All right, so on the left you see our kit, which has the black foam. It will come with the domed pad tubing, the transparent drape, and then the adapter connector that will go with whatever machine that you're using. And the supplies that you're going to need, the nurses, to bring to the table are gloves. They're going to need the normal saline, dependent upon whether or not they're using something like a silver. At times they may need sterile water instead. They're going to need some, gauze, sterile gauze or clean gauze to clean up, the scissors, and of course, we always recommend some type of a protective barrier wipe, something like a skin prep. Okay, so now the nurse is going to inspect the wound, so she's going to do a full assessment of the wound and decide if negative pressure is even appropriate. There are certain wounds that negative pressure would not be appropriate with, and that's something that the clinical team should be aware of. They're going to look at the condition of the peri-wound, the type of drainage, is there any wound odor that would indicate infection, is there any undermining or tunneling, because again that would also depend on what type of foam that the nurse would choose. Some type of wound measurement should be, of course, depending on policy, they should document that with each dressing change. At this time, once the wound has been irrigated and assessed, now you're going to apply the protective barrier like a skin prep. Sometimes I suggest that going around the wound, that they may actually want to put something like a transparent drape, a border that would further protect the wound, especially on shallow wounds. And that's just going to protect it from not getting that wound to actually grow larger. So on the next screen, okay, so if you had something like a tunneled area or even an undermined area, the hydrophilic white foam actually would work better. It has better strength. It's not going to break away as much. And as you can tell, we're putting it and we're tucking it in very gently into that area. What the clinicians have to realize is that all dead space in a wound has to be filled. If there are gaps and they are not getting enough foam in, then those areas will not actually heal. It will leave gaps opening and will probably reopen at some point. So we want to fill it, but we don't want to overpack. The other thing I recommend is if they are putting in these into tunnels or undermining, that they leave enough of a tail that they can very visually see it, so that when they change the dressing later, it can very easily come out. Okay. We have an open antimicrobial silver wound dressing kit as well. So if they do need silver, then we'd actually include that in the kits. And then they could cut the shape, and that would lay down into the wound bed, and then it would have the foam that would go over it. Okay, so now we get to the black foam. So we've already dealt with our undermined area. Now we're going to take and we're going to cut the black foam, and what we're going to do is always cut way away from the wound. We're very proud of our foam in the way that it does not shed as much as some people's out there, but at the same time, all foam when being cut could put small pieces that could then grow into the wound, and that would cause definitely a issue in healing. So we want to measure it to shape. I think this is where it's very important that the nurses realize that they have to scale, not just width and length, but they have to scale to depth. So we don't want to see that popping way up over the wound, because as the wound compresses down and the foam compresses down, it could put too much pressure on that wound bed. So we have to cut it to fit the wound, not leave gaps, but not to overbulk it. We shouldn't be pushing the foam in. The dressing size should definitely allow for the dressing to fill, as I said, wound cavity without overlapping onto the intact skin. And that's where, by bordering the wound with the transparent, it's definitely helpful. Okay. So the nurse is going to gently place the foam into the wound cavity, covering the entire wound bed, not forcing, not causing any more damage to the tissue. And the white foam is in there. So now, on our drape for this particular wound, you can see there's probably just too much drape. We don't want to over drape. So you would cut that drape down to fit by maybe cutting across a little. And you may be actually using part of the drapes as part of your bridge that would go under. So that's another thing. They can just follow the lines and cut across to make it easy. Love our drapes as a clinician because it's a 1, 2, 3 step. You'd be surprised at how many times you can do that wrong without these steps. So by pulling off tab 1, then you're going to place it down over the foam that you've put in. And then you'll be able to take tab 2 off. And then tab 3. Oh, here, I think I'm, okay. You're going to cut a very small hole, actually probably the size of about a nickel. Is that what we're saying?
Quarter.
Oh, I guess about a quarter, into the center. So that can be done either prior to placing it down, which is the way I like to do it, or some nurses will actually pick up a little piece of the film and cut so that there's a little tiny hole the size of a quarter there that the dome pad will then fit over. I do want to say that when you're putting on the op site, you want to seal all around the edges, but it's not important over the foam to push, and it will help. It will sort of collapse. It needs a little bit of breathing room to be able to actually collapse down. So we don't want to stretch it too much as we first put it on. Before you peel tab 3, just make sure everything is positioned. Now we get to the dome, and this is how simple it is. You're just going to take the backing off the dome. And you're going to place the dome right over that little area that you cut the 1/4-inch hole. You do not want to cut a slit in the drape because the slit can actually grow. So we really do want them to learn to cut a hole, and that way it won't rip further. You want to gently lift the drape, again, with your thumb and cut that, or again, I like to pre-cut my holes before. Is that... I'm just checking one thing.
It's no longer.
Okay. So where it does say our medium kits have the custom-built hole, that's not actually longer the case. The nurses actually didn't like that as much, and they really like to be able to cut their own. Okay, so make sure everything is properly aligned and the dome pad is over the center of the hole. And then what now is when you're going to start to seal. There's no reason to overpress, but you definitely want to make that nice seal, especially with the warmth of your hands, to get that transparent to stick properly. And then you always want to check that you got a nice seal, ensuring no leaks and stuff in the drape. Once you do have that tight seal, you want to peel off the backing liner, and then those blue tabs will come right off. Pat around the dome to ensure everything, and this is where you're going to connect your adapter tubing. So sorry. We're playing over here. We're going to connect the adapter tubing to the end of the dome pad tubing. An adapter is required, and again, that has to do with the fact of it will match up with different pumps. So by having that small adapter, which is now a lure lock system, so it will not come off, it won't pop off. And every foam kit will have an adapter included with it. So now all you want to do is connect that adapter tubing to the pump canister tubing. And then before turning the pump on, you want to make sure all tubing clamps are open. I will also say here, when you do turn it on, to maybe choose a lower pressure. Instead of turning it on at 125 millimeters of mercury, I probably would start it, especially if the patient had a sensitivity or a painful wound, maybe at 60, maybe 80 millimeters of mercury before moving it up. Let's see. Once the negative pressure is turned on, everything will start to compress. And depending on the pump that you use, some compress right away, some are a little slower to pull the air out. But just give those pumps time because that actually, the slower they are, the actual less pain to the patient. When everything compresses down, you'll be able to tell. It has a very firm feel to it. If it feels boggy or mushy, then not enough air has come out and there is a loss of seal. which then you will probably have a pump that will start eventually alarming. Now that is just a very basic on how to do one of the dressings, and that included no bridging.